Welcome to the recorded version of Measuring Outcomes to Evaluate Dementia Programs and Interventions, Strategies, Challenges, and Benefits from January 30th, 2019, part of the National Alzheimer's and Dementia Resource Center webinar series, sponsored by the Administration for Community Living.
Thank you so much, Steve. Welcome to the webinar, everyone, on measuring outcomes to evaluate dementia programs and interventions. In this webinar series, the Administration for Community Living's National Alzheimer's and Dementia Resource Center has partnered with the American Society on Aging. We're so pleased to have all of you in attendance today. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi, everyone. On behalf of the Administration on Aging at the Administration on Community Living, I want to thank you very much for taking the time out of your busy schedules to attend this very important webinar on measuring outcomes. Evaluations are so important in all of the work that we do, understanding how it impacts the people we're serving. I'd like to thank Michael Lepore, Stephanie Hughes, and Elizabeth Blount for giving us their time and sharing their wisdom with you. We are greatly appreciative. So with that, I'm going to send it back to you, Sari.
Thank you so much. So as you just heard, for today's webinar, we'll be hearing from Michael Lepore, who is a Senior Health Policy and Health Services Researcher with RTI International and an Adjunct Assistant Professor of Health Services, Policy, and Practice at Brown University. For the past 5 years, Michael has worked with the National Alzheimer's and Dementia Resource Center at RTI International. Stephanie Hughes is a research public health analyst at RTI International and works with the National Alzheimer's and Dementia Resource Center as well. Stephanie has 13 years of Alzheimer's and Dementia services experience. She provides technical assistance to the Administration for Community Living's Alzheimer's grants and is a lead on evaluation and reporting for the grantees. Lastly, we'll have Elizabeth Blount, who is a care consultation program manager at the Rosalind Carter Institute for Caregiving. Elizabeth assists with licensing, training, and technical assistance to select organizations that are offering the BRI Care Consultation Program, which is an evidence-based coaching and support program developed by the Benjamin Rose Institute on Aging. So I want to turn it over to our three speakers to begin their presentations today. Michael, we will start with you.
Thank you, Sari and Erin, for the introduction and for getting us started today. My name is Michael Lepore, and as Sari explained, Stephanie Hughes and I will first present on measuring outcomes to evaluate dementia programs and interventions, and then Elizabeth will cover some more concrete experiences in conducting evaluations. To get started, we're going to first review some multiple methods for collecting outcomes data. I'm just going to give a brief review of what we will cover first today. We'll discuss the pros and cons of using outcome data collected from proxies instead of directly from people with dementia. We will review some of the benefits of using validated outcome measures. We'll provide some resources for identifying validated outcome measures that you can use, and we will describe some considerations for selecting which outcome measures best fit your programs. And to start, I just want to review what we mean by measurable outcomes. A measurable outcome is an observable end result that describes how a particular intervention benefits consumers, and it may demonstrate functional status or mental well-being, knowledge or skill or attitude, awareness or behavior, one of many domains. And outcomes from projects that target individuals who are living with dementia and their caregivers often include, but are not limited to, changes in quality of life of the person living with dementia, changes in unmet needs, changes in stress and or burden, those are commonly caregiver measures or outcomes, changes in the caregiver's self-efficacy, and changes in the responsiveness or the cost-effectiveness of a service delivery system. It is important to clarify that such measurable outcomes are different than measurable outputs. Examples of measurable outputs would include things like the number of clients served, the number of training sessions held, or the number of service units provided. So those are examples of outputs, which are quite different from outcomes. We'll be focused on outcomes today. Now that we've reviewed what we mean by measurable outcomes and what they are, let's turn to why we measure outcomes. So outcome measurement results can be particularly useful for several purposes. For example, outcome results can help you decide if you should continue doing what you are doing in an intervention or in a program, such as by determining if the outcomes of the intervention are favorable. If they're not, then that intervention may you may not want to continue that intervention. Outcome results also can help you decide whether and how to change what you are doing. For example, outcome measurement can help you determine if an intervention achieves better outcomes when there's a specific adaptation made to that program or intervention. And outcome results also can very importantly help you encourage participation and support from others, including program participants, the individuals who are being served in the community, but also funders. And these can be particularly helpful by showing the favorable outcomes of the program. So with the goals of a program in mind, a logic model can be a very useful tool for planning and evaluation and for identifying the outcome measures that would be used. The logic model would show the basic structure of the program, and what is shown here is the outcome measurement portion of an example logic model. A full logic model might start with some earlier columns than what is shown here, and those would include inputs such as the resources that you need to implement your program, like the key staff and any necessary equipment that you might need. And those inputs, those create outputs, such as the intervention you are implementing. The example here shows the intervention example of COPE, with the example output goal of providing COPE for 100 persons with dementia who live alone. Then, as a result of participation in the intervention, you would seek to achieve certain outcomes. And outcomes can be immediate, they can be short-term, medium-term, or long-term, and they can be positive or negative or neutral. The example shown here is an outcome goal of improving, so a positive goal of improving the quality of life of the person with dementia who's living alone. And then as the outcome measurement plan shows, this outcome would be evaluated at 30 days following the intervention. So with this sort of basic structure in place, evaluation plans can build on the logic model so that it's clear which outcomes need to be assessed or measured, and the logical pathways by which you expect those outcomes to occur, which interventions will impact which outcomes. So for example, in this case, in this element of the logic model might be summarized as saying participation in COPE is expected to improve quality of life for at least 30 days after completion among persons with dementia who live alone. And then a full logic model can be built out with a separate row just like this for each of the interventions that would be implemented. And there are several different methods for measuring outcomes. We'll briefly review a couple of those main methods here. First, surveys and questionnaires are measurement techniques where participants are asked a series of questions and their answers are recorded. Those questions may be open or closed-ended, with closed-ended questions being those yes or no questions that provide quantitative data. For instance, with a yes or no, those could be quantified as ones or zeros in some measures. Whereas open-ended questions usually generate more qualitative data, but those answers can be coded to yield quantitative data. So while qualitative data, like a paragraph of text that someone might provide in response to an open-ended question, those answers, that paragraph of text, can be coded numerically in some instances. Another method for measuring outcomes is observation, where operations or activities are directly observed. These are useful when the required information can be obtained by simply watching and listening, and these can be particularly helpful for answering questions about whether a program or an intervention is being delivered and operated as planned. So if there is fidelity with the plan and how it is being implemented, and this can help better understand how the context of the situation may be impacting either implementation of the program or the outcomes that are being achieved. Interviews also can be used. This entails a conversation between an interviewer, a researcher, and the person with dementia perhaps, or a caregiver who can provide input on the issue being evaluated. Interviews will follow a script or a guide, and those can include probing questions that may be optional to dig into details more thoroughly when relevant for that interview. And these questions are usually open-ended, and then the data are usually qualitative, but quantitative data also can be collected in an interview format. And we'll briefly just review focus groups, which are small group discussions where a moderator would use a question guide, like an interview guide, to introduce topics of interest and, again, have probes for further discussion. And these data also are usually qualitative, but short quantitative surveys can be conducted as part of a focus group to get more quantitative information. For instance, a focus group could begin and or end with a short survey. And finally, secondary data can be used from existing data sources like medical records, where outcome data are abstracted or pulled out of those medical records. And those data are usually quantitative and they're standardized, but they're not necessarily tailored to the evaluation that's being conducted. So there are some pros and cons. And when participants in data collection include vulnerable people, such as individuals living with dementia, it's particularly important to assess their capacity to participate in data collection. So some people with dementia, particularly those in early to moderate stages of Alzheimer's disease as an example, they can participate in data collection, but because dementia is progressive, that capacity to participate will decline over time. So decision-making capacity depends on the individual's capacity or their ability to communicate fairly consistently, to understand basic information about their choices, and to evaluate the implications of their different choices, such as whether or not to participate in data collection, and to understand those risks and benefits of their options. And because these decision-making capacities change over time and different decisions require different levels of capacity, even a diagnosis of dementia or a specific score on a cognitive test might not be the only criterion for determining an individual's decision-making capacity. So several decisional capacity assessment tools exist that can help researchers or evaluators in determining the capacity among individuals with dementia. However, none of these specific instruments are considered a gold standard for determining capacity to participate in data collection. However, there are examples of tools that have been developed over the past couple decades. These include tools such as the evaluation to sign consent, the Hopmont Capacity Assessment Interview, the Capacity to Consent to Treatment Interview, and then the MacArthur Competence Assessment Tool Treatment. And additionally, difficulties with naming or delayed memory can indicate limited decisional capacity among people with dementia. So these are a variety of tools that may be helpful for determining capacity of individuals with dementia to participate in data collection. And finally, before I pass it off to Stephanie, I just want to cover some pros and cons of engaging with proxies. So when an individual with dementia does not have the capacity to participate or to provide informed consent, then engaging a proxy, such as a caregiver or a family member, is a valuable option for data collection. But there are some risks. For example, proxy decision makers, including family members, commonly make research enrollment decisions, so that decision of whether or not to participate in the study, can make those decisions based on what they think will maximize the well-being of the person with dementia, not a substituted judgment of what the person with dementia would decide, which is different. Furthermore, the data that are provided by proxies commonly differ from the data that are provided by the person living with dementia. For example, individuals who are living with dementia have been found to have higher hopes for their quality of life than their caregivers have for them. So while engaging proxies in data collection can be valuable and indeed can be necessary to evaluate some issues, when doing so, these are important possible shortcomings to take into account when engaging proxies. Pass it along to Stephanie now to pick up on selecting appropriate outcome measures. Stephanie?
Thanks, Michael. Good afternoon, everyone. I'm Stephanie Hughes. I'm with the National Alzheimer's and Dementia Resource Center. And so in my section today, I'm going to be talking with you about how to select outcome measures for dementia programs, including questions related to defining the outcomes to measure, identifying quality outcome measure instruments, and other considerations related to how the data is collected. So one of the most important steps before choosing an instrument or tool for measuring outcomes is to be really clear about what the intended outcome of your program or intervention is. And Michael touched on this as well in his section when he walked you through the logic model example. But it's really important to give sufficient thought to this question in order to select the most appropriate measures. So as an example, let's say you're developing a program that sends friendly visitor volunteers into the homes of people who are living alone with dementia. So there could be several possible outcomes related to this type of program. You might be looking to improve the safety of the person with dementia. You might be trying to link them with more resources in the community or help them feel less socially isolated, et cetera. So there might be one key outcome that you're really focused on, or there might be more than one. But it's important to think about that. What are you really trying to accomplish before you think about how to measure it? You also want to look closely at how you're defining your outcome. So for instance, many caregiver education programs may state that they have a goal of increasing the knowledge of the participants, and often you may use like a pre and post test that measures whether specific information has been learned. And that might be the best tool for your program. But if you dig a little more, you might think about the fact that in addition to increasing knowledge, these programs can often increase a sense of self-confidence or what's often called self-efficacy as well. And that type of outcome can be really closely correlated with other outcomes of interest, such as levels of caregiver depression. So just kind of thinking through what it is you're really trying to impact and what's going to be useful to assess and demonstrating that impact. Finally, you also want to make sure that the outcome is reasonable given the intensity of the intervention. So going back to the example of the caregiver training session, if you have a 1-hour education session, it can be hard to demonstrate a change in behavior from a relatively brief intervention like that. So it might be more realistic to think about, doing a brief measure of the change in knowledge or attitudes. And sometimes we're not sure really what a reasonable outcome is. So if you're finding yourself in that situation, one thing that you can do is consult the research to see, for programs that are similar to yours, what kinds of outcomes have been obtained from those types of interventions, and that might give you some good ideas to start with. So once you're clear on what you want to measure, you need to determine how to measure it. And so I just want to touch on the importance of using quality instruments to collect your data. And there are two factors that are really important in using a quality tool for measuring outcomes, and those are reliability and validity. A reliable measure is one that gives you the same result each time you use it, while a valid measure is one that measures what it says that it measures. And so ideally, your outcome measure is going to address both of those points. So in the first picture here of this bullseye, you see that we're measuring the right thing. The arrows are kind of centered around the target, but they're not very consistent or reliable. So that might be an example of something that's valid but not reliable. In the second example, you can see, okay, we're getting really precise measures here that are all clustered very closely together, but they're not touching the bullseye. So it's a reliable measure, but not valid. So it's beyond the scope of this session to really go into more detail on this topic, but I wanted to touch on these concepts because not all outcome measures or tools are created equal. And this is something to really think about in considering whether to use an existing measure that's already been tested or to develop your own. So I'm going to argue for the benefits of considering using existing validated measures. And the good news is that for most of the outcomes that might be important for your dementia programs and services, there are many existing evaluation tools that have already been developed and that have been tested in terms of their reliability and validity. And so there are several advantages to using these existing measures. First and foremost, if you use something that's already been validated, you know that you're actually measuring the intended outcome, which is pretty important. Using a measure that already exists also saves you time. You're not having to reinvent the wheel and creating a brand new tool, which can be quite time consuming. It's also an indicator to others, such as funders, that you really care about the quality of your evaluation if you're taking the trouble to find an existing measure that has already been tested. And finally, although it can be difficult to compare apples to oranges among different programs, using the same instrument that other programs have used may at least give you a general sense of how your results compare to those of other similar programs. So it can be useful in that respect as well. So once you've identified this outcome that you want to measure, where can you find some of these validated outcome measure tools that might be appropriate for your dementia services and supports? This was a need that we saw within our resource center, and so we've actually worked to compile a list of some of the common and easily accessible measures. And our goal in putting this list together was really to try to eliminate some of that time and legwork that is often spent searching for these tools. So we developed this list a few years ago. We recently updated it to include many more instruments. There are now 73 different items on the resource list that assess a whole range of different possible outcomes, including outcomes for people with dementia, outcomes for their caregivers, and some outcomes related to professionals. So some of the different outcomes that are measured include things like caregiver burden, level of cognitive functioning, assessment of safety and other risk factors, and quality of life, including quality of life for the person with dementia as well as quality of life for their caregivers. So what we also did with this list is we've included links to almost all of the instruments so that it's very easy to access them online. Where available, we've provided information on how to administer these tools and score them, as well as information about any published research that's been done already on these instruments. And finally, we've included information about whether any special permission needs to be obtained from the original researchers in order to use the tool. Most of these require minimal effort in that regard, but that is an important factor, is that sometimes you do need to get that permission before you start using the tool in your programming. So I've provided the URL here where you can access that list, and it's also included later in the presentation if you're interested in checking that out. So as you get to the point where you've identified your outcomes and you're looking at selecting a measure, there are some other considerations that you'll want to think about as you're choosing an instrument to use. First, who is collecting the data? With some tools, the respondent might fill it out on their own. You might need a staff person to administer it. You'll want to consider whether your staff will need special training to use this tool, or whether there might be any particular level of clinical skill that's needed in order to use it. Another question is who is responding. As Michael talked about, this is something that's really important when you're collecting outcomes on persons with dementia. Are you going to be asking them to complete the tool, their caregiver, another professional? You want to make sure that you're selecting something that's going to be appropriate to your program and audience. And then there are a number of other questions, like how is the data going to be collected? Is it going to be in person, over the phone? How much time is needed to complete it? In general, you want to try to keep the burden low for both your staff and for the participants, but you also have to balance that with your need for information on your program. And you'll want to think about how this data collection fits in with kind of the flow of your programming. You know, are you going to have the data collected during an intake appointment? Are you going to send paperwork to be filled out prior to someone starting services? So how can you collect this data in a way that fits in with the flow of your services as much as possible? And finally, there are different possibilities in terms of when you collect the data. As I'm sure many of you are familiar with, the gold standard for evaluation really is the randomized controlled trial, where you're collecting some data before and after an intervention. That type of study is rarely used outside of within the practice world just because of how resource intensive it is. So for the type of evaluation that most dementia services providers are conducting, where the focus is really mostly on providing services rather than conducting research, there might be a variety of approaches that you take to collecting data. So for something like a very brief training session, it may only be feasible to administer a short assessment after the program. And that can be a nice, simple way to get some data. It also has some limitations in that if you're only collecting data after a session, there might be some bias in terms of asking people to report whether they learned something or not. It's usually preferable, if possible, to collect some data on a pre and post level. So at the beginning of a program and at the completion. And that allows you to assess whether change has occurred or not. And finally, for some programs or interventions that are more intensive, such as like an ongoing case management service that might be provided over many months, in that type of situation, you might think about collecting data at multiple points in time, which is more resource intensive, but then also gives you a richer picture of the impact of your programming. So I'm going to move along now. Michael and I did include some references here if you're interested in learning more about any of these topics. I've also provided our contact information if you're interested in getting in touch with us with any questions after the program. But now I'm going to turn it over to Elizabeth to talk about a real-world application of outcome measurement.
Thank you, Stephanie, and thank you, Michael. As they said, my name is Elizabeth Blunt, and I'm with the Rosalind Carter Institute for Caregiving. And so I'm going to be talking about how measured outcomes helped propel the implementation growth of an evidence-based caregiver support program in the state of Georgia. Please keep in mind throughout my slides that the implementation growth of this program has really been a collaborative partnership not only between the Rosalind Carter Institute but the Benjamin Rose Institute on Aging, as well as the Georgia Division of Aging Services. So to give you guys some background on the program that I'm referring to, the BRI Care Consultation Program, just so you know, the BRI and BRI Care Consultation stands for the Benjamin Rose Institute, who are the researchers and developers of the program. And this program is an evidence-based information, coaching, and support program for adults with chronic health conditions and their caregivers. When this program was originally demonstrated in the state of Georgia, it was just focused on serving family caregivers who were caring for care recipients that had dementia. And that has since expanded But know that when we're talking about outcomes and results of those, we're specifically talking about those caregivers caring for individuals that had a form of dementia. So the program is delivered telephonically or via email, which means that all of the work and communication that is happening between the professional that's delivering the program and the client is happening over the telephone or via email. And this makes it really beneficial because really anyone, anywhere can be served. In Georgia, we have lots of rural communities, and so this is very beneficial when we're talking about delivery method. And it's also beneficial for maybe caregivers that aren't living in the same area as their care recipient. This also makes the program very resource effective as far as time, money, and even manpower. The program is personalized and tailored, so when a client enrolls into the program, they are going to be addressing their pressing concerns or issues both in the present and maybe if they have future concerns or issues in ways that are really tailored to their preferences as a client. Not everything is going to work for everybody, so what is being addressed and the way it's being addressed is tailored to the client. The program provides ongoing support through regularly maintained ongoing contacts that are going to be happening throughout the duration of service. And throughout those ongoing contacts, practical solutions are going to be developed to present concerns or future planning and prevention. So again, it's going to be based on client issues as well as client preferences, and adjustments to changes in care can certainly be made. And as far as the service delivery period, that's really determined by the site that is delivering the program. A minimum of 6 months is usually recommended. Sometimes 9 months might be another recommendation. But keep in mind for Georgia sites, we serve families for up to a year. There are 3 key components to the program. The first is initial assessment, and it's what it sounds like. This is when the client and the professional are working together to identify those unmet needs or issues, both in the present or maybe some future concerns that they have for both medical and non-medical issues for themselves as a caregiver and their care recipient. The difference between this program and some others that are supporting caregivers and those they care for is that this assessment is happening very gradually, which is very important to not be assessment heavy before problem solving can even begin. Families really enjoy that they can begin digging into what's going on right away. So once those unmet needs or issues are identified, then the client and the professional collaborate together to develop a step-by-step, simple and achievable tasks to address those concerns. And again, these are for present or future concerns, and it's happening gradually. So that means as soon as there's a pressing need or issue, that problem solving can really begin in the first call. And then the last key component here is maintenance and support. So much like at the beginning of the program, when those potential areas of need are being assessed to see if there is a need, that's going to happen later on in the program as well to see if there have been any changes, if the needs that were originally identified were fully addressed, things like that. But as well, ongoing contacts, like I said earlier, are going to be maintained between the client and the professional. And so they're able to kind of monitor that care situation, continue assessment, develop and follow up on action steps, and then provide support. For just a little bit of background on the program development history in general, the program's actually been developed over the past 2 decades through 9 different research demonstrations and projects, one of which was in Georgia from 2010 to 2013, which was funded by the Administration on Aging, Administration for Community Living. And there are actually 3 phases to this The original was that 3-year grant demonstration. Then there was a pilot project at an area agency on aging of the program, and then there was a statewide expansion. So to give you a little bit of background on the relationship between the collaborative partners for this project, because this is important to understand when we're talking about what we measured and how. BRI were actually the researchers and developers of the program. The Rosalind Carter Institute partnered with BRI on licensing, training, and technical assistance of select sites delivering the program. The Georgia Division of Aging Services were in support and expansion of the program as an alternative to such things like costly case management. And then the area agencies on aging, they're the licensees and the deliverers of the program in Georgia. So the Georgia Division of Aging Services and the area agencies on aging identified some challenges with serving families that were caring for someone that had Alzheimer's disease or related dementias. And some of those challenges were growing waiting lists for services, underutilized formal services, programs serving both caregiver and Alzheimer's disease or related dementia care recipients, and effective serviceabilities using face-to-face methods, because again, that's a good way to deliver a program, but it can be a little costly at times. And so the BRI Care Consultation Program was chosen because of its high efficiency level. Again, it's very cost-effective. The ability for the client and the professional delivering the program to maintain frequent contact. Also having an information system known as the Care Consultation Information System that guided program delivery to ensure fidelity and high quality level of service. And as well, the program was shown during the other grant demonstrations to be really effective in a wide range of agencies. So there were 3 different area agencies on aging that originally delivered the program, and the eligibility criteria for participants in the program were care receivers with or without a formal dementia diagnosis, care receivers living in the community with a primary caregiver, and that caregiver may have lived in the home with them or elsewhere, a care receiver living in a community without an identified primary caregiver, and then the ability to read and speak English. So in talking about the measurable outcomes, there were actually pre- and post structured research interviews that occurred with the family caregivers that participated in the program. And during those structured interviews, quantitative outcomes measured by data were taken, and the instruments that were utilized during those interviews, if you have specific questions on those can be found on the reference slide. But please note that the instrument tools that were utilized were the original ones in the studies that were used to test the efficacy of the BRI Care Consultation Program previously. But the measurable outcomes that were established for the project were enrollment, attrition, caregiver depression, caregiver confidence or self-efficacy, caregiver social isolation, as well as caregiver health strain. And then a caregiver needs met, which included a total needs met as well as 8 categories of needs, which you can all see listed on the slide here. So in talking about the results of each of these measurable outcomes, and again, I can't get too deep into each of these, but as far as enrollment and attrition, for enrollment, it actually exceeded the overall established goal for the 3 sites. Attrition was slightly higher than the national average. For depression, there was actually a decrease in caregivers of persons with high behavior problems. And then for caregiver confidence and self-efficacy, there was an increase in the total sample as well as caregivers of persons with high behavior problems. As far as social isolation and health strain, there was a decrease in caregivers of persons with high behavior problems, and for social isolation, as well as with caregivers caring for persons with high cognitive impairment. And then for needs met, there was actually an increase for needs met in the total sample. So in part to the results that you were shown on the previous slides, like decreases in unmet needs, high enrollment, in combination with such factors as ongoing support and advocacy for the program by implementation partners, were really essential for the initial and sustained implementation of the program. And it was through that original demonstration that future goals for the program were established and are being continued today for the expansion and adoption of the program statewide. So some of the goals that were established for expanding this program were maximizing the use of limited resources, because again, the program is very cost effective, enhancing sustainability of aging network through fee-for-service options, infusing evidence-based programs throughout the aging network, improving coordination between formal and informal care, improving the focus on prevention and person-centered care, and improve availability of services in rural areas. So to talk about where we are now in the program, we're really in a continued scaling of the program in the state of Georgia. As far as our implementation sites, those have actually grown from the original 3. Now there are 9 different area agencies on aging that are delivering the program directly across the state of Georgia. And the 3 remaining area agencies on aging that are not delivering directly can refer clients to be served in the program. And this has been great because different area agencies on aging are both reflected in rural and urban communities throughout the state of Georgia. Also, with ongoing training and technical assistance that's being provided, BRI has training and technical assistance provided as part of a standard licensing agreement, and then RCI provides additional comprehensive and tailored training and technical assistance to select sites like those in the state of Georgia that are delivering the program. And this really helps ensure continued high-quality delivery and program fidelity. Also for the families being served, because it was found to be so effective for families caring for someone with Alzheimer's disease or related dementias, it's been opened up to all types of caregiving families, but we still see a lot of families being served that are caring for someone with Alzheimer's disease or related dementia. We're also developing a private pay fee-for-service model, which is very important for sustainability. And then as far as data collection, that is really continually happening throughout the duration of the program because of that web-based record and information system known as the Care Consultation Information System. And it has so much more built into it, those assessment and action step development tools, reporting features, standardized protocols, things like that. So here are some references if you are interested in taking a look at some of the things that I discussed. If you would like to contact or keep up with some of the implementation partners for the BRI Care Consultation Program in the state of Georgia, here is our contact information. And with that, I will say thank you very much, and I will turn it back over to Sari.
Great. Thank you, Michael, Stephanie, and Elizabeth for your presentations. We have quite a few questions that have come in, and we'll get to them very shortly. I just want to let everyone know that you can enter questions into the question and answer pod of the webinar platform. So I'm going to start getting to these questions right now. Michael or Stephanie, can you talk a little bit about your thoughts about self-report measurements of outcomes, especially when a person is, just stating quality of life has improved or diminished as a result of an intervention. Are there any studies out there that talk about the specific validity of self-report that you can think of?
So, although not drawing immediately on the literature, just drawing on what I remember, one of the risks I would raise about that sort of self-report is the risk of sort of social desirability bias, where people tend to report what they think others want to hear, and so they may say that their quality of life is much improved because they think that the person who's asking them that question wants to hear that their quality of life has improved. One idea that comes to mind when doing that sort of self-report, because it is still valuable information, and the primary source who's reporting that is probably the most valuable source to hear from, is considering if there are certain components of quality of life that are most important to the individual. So, for some people that might be, being able to have continued engagement with their faith community or time with their grandkids. And so it might be that asking for self-report in a method that asks both what their priorities are and the extent to which those priorities are met might be a nice way of overcoming that social desirability bias and getting even more detailed information that that is a higher level of burden, so it depends on the number of people from whom data are being collected, but that is one approach that might be considered. And then the last item that comes to mind for me that I'd share is, if doing that sort of self-report about quality of life following an intervention, that would seemingly need to be done, at least 30 days after the intervention, to indicate that quality of life has improved, because any shorter than that, and it might be hard to say that, quality of life has improved, based on a more shorter time period. Stephanie might have some additional insights on those items too.
I would just add, I would totally agree with the points you made, and I would just add to your first point about kind of breaking down those different elements. I mean, with that type of question, it is somewhat subjective, but it's not the same as taking somebody's blood pressure or something. But there are many existing tools for measuring quality of life that do break it down into some of those different key elements. So I think that can help get at some of that bias, or at least get you down to a more granular level, like Michael was saying.
Great, thank you so much. So Elizabeth, the next question is for you. There's quite a few questions that are coming in about asking about the private pay fee-for-service model that you mentioned in your slides for BRI. Can you talk a little bit about what the fee-for-services is and who pays the fee? Does it coordinate with any systems such as Medicare or Medicaid? If you can talk a little bit more about that, that would be helpful.
Sure. What I can tell you is that we are still in the planning phases right now. We haven't rolled it officially out with the program yet. So, not too much to report. We're doing lots of research right now, seeing what other programs have been delivered on a private pay fee-for-service model and what that has looked like, and seeing what has been effective and what hasn't been effective. So for more information about that, all I can really say is stay tuned, because that is going to be rolling out very, very soon. It's just right now we're still in those planning phases.
Great, thank you so much. There's a question that came in asking about including people living with dementia and reporting their experiences of programs or interventions, and who in a situation would decide their capacity to report those experiences. And the question is specifically, have you heard of any interventions where the person with dementia can challenge a decision regarding their capacity or inability to participate based on their capacity?
So
That's
just
I just want to share that I think that's a really great question. I don't have an immediate answer. Others on the call might, but very good question.
Okay. We will, if we do find the answer to that question, we'll get back to the person who asked. Let's see. Elizabeth, can you talk a little bit about the other types of caregiving families that are part of the BRI Care Consultation program right now? What other types of caregivers are you including? What other types of conditions besides dementia?
Sure. So the main thing to remember with that is that the program is really designed for caregivers and caring for someone that has chronic health conditions. And so if it's a chronic health condition, then really it can be served within the scope of the program. Other than dementia, some other common chronic health conditions that the sites will often see: diabetes, heart disease, maybe even some physical or developmental disabilities. It's really just a wide range of chronic health conditions or illnesses that can be served within the program. And of course, it can depend as well on the site. There might be some sites, whether that's in the state of Georgia or elsewhere, that specialize in serving a population of specific type of individuals that have specific types of chronic health conditions, but we see a really wide variety.
Great, thank you. Stephanie, you might be able to answer the next question. Someone wrote in to ask if there have been any specific measures that have been adapted for cultural competency or have been tested for cultural competency for various racial and ethnic groups, the disability community, et cetera.
Yes, absolutely. I can't give a lot of specifics right off the top of my head of which ones, but there absolutely are many measures that have been tested, particularly in terms of, working with different ethnic groups, different languages. A lot of measures have actually been tested in other countries as well. So there is a lot of that. I'm not as familiar with testing that's been done in relation to disabilities and that sort of thing. There may be some of that, but I'm not as familiar with that. A lot of the links within our resource list will take you to more information about those tools, and often you can find versions that have already been translated and that have already been validated for that language. So that's a great question.
Great, thank you. Elizabeth, we had a question come in that asked if, besides the caregiver outcomes for BRI Care Consultation, were any outcomes measured that focused on the care receiver?
As far as outcomes that were focused on the care receiver, something to remember, and I think this ties back to some of the earlier points that Stephanie and Michael made about getting information from Proxies. So the way that the program generally works is that you might have a caregiver that is caring for someone with a chronic health condition, and they may not be able to participate themselves. And so in assessing some of those potential areas of need, the caregiver can kind of answer questions on that, whether their experiences with that or otherwise. And so that's something to remember generally about the program itself. But as far as measuring in the original implementation, that's something that if that person has more specific questions about, they can contact me directly, and I'd be happy to answer what I can.
Great, thank you. Another question that came in, sorry, my questions disappeared for a second. I just found them again. Another question that came in was asking, if you're using an evidence-based intervention, is it necessary to conduct an evaluation, or can you assume that the same outcomes will be achieved as long as the intervention is delivered with fidelity? So, Michael, you might be able to comment on that, and Stephanie and Elizabeth, you might want to add in your own responses as well.
Yeah, the one thing that comes to mind for me of great importance is a lot of the evidence base is established under very controlled circumstances, like a randomized controlled trial, and implementing an evidence-based intervention in the community might lack a lot of those controls, and so it could be different in that sense. So evaluating a intervention when implemented in a community is valuable for showing that intervention's sort of value in that community, because every community is different than any sort of scientific controlled experiment through which the evidence would be established.
Great, thank you. Okay, Elizabeth, there was a question about caregivers who are accepted into the BRI Care Consultation Program. Are there any limitations of those who can be accepted into the program who are caregivers in terms of their ability to speak or read the English language?
So as far as specific, I guess, eligibility requirements for someone participating, so delivery model is telephonic or email-based, so communication can happen completely over the telephone. So if you have a caregiver that, might have trouble reading printed materials or something like that, then they can certainly communicate just verbally over the telephone if needed. And as far as any other eligibility requirements, again, that can really depend on the site that is specifically delivering the program. So whether that's age or something like that might vary from site to site that is delivering the program directly.
Great, thank you so much. Well, there are quite a few questions remaining, but we are about to run out of time. So I did want to take a moment to thank everyone again for joining us today, and to thank the speakers for their excellent presentations and response to questions. We will be having another webinar in this series on March 13th that will focus on vascular dementia. So please take a look for that registration link on the American Society for Aging website. We would love to have you again for the next webinar. And I will turn the program over to Steve for some final remarks.